Hey guys, this is John with nrsng.com and nursingstudentbooks.com. Thank you so much for checking us out. Today we're going to talk about neuroanatomy, and specifically we're going to talk briefly about the microscopic anatomy and physiology of the brain. So we're not going to get into the big picture of some of the anatomical structures and things like that, but we're going to talk more about the microscopic anatomy. If you want to learn more about us, you can go to nrsng.com or nursingstudentbooks.com, where you can find all of our study aid materials as well as apps, NCLEX prep tools, and all kinds of great study guides. All right? So first, let's talk about, essentially what we're talking about with the neurological system is there's different components of the neurological system, right? We know that we have the CNS, we have the PNS, and we have the ANS. Okay, so this is central nervous system, and then we have, of course, our peripheral nervous system, and in the ANS we have our sympathetic and our parasympathetic. And this is going to be like your fight or flight. Okay, so those are really the components of our neurologic system: CNS, PNS, ANS. And ANS, of course, is autonomic nervous system, which is broken down further into sympathetic nervous system and parasympathetic nervous system. But what we have microscopically within there is we have different nerve cells. Okay, so we have our neuroglia, which are broken down to a few different types of neuroglia, and then we have our neurons. Okay, so the neuroglia actually makes up about 85% of the cells within the CNS, and these are also known as glial cells. So if you've heard of like a glioblastoma, a type of glial cell tumor, or possibly, you've probably heard of glial cells before. And the reason for that is because they are incredibly numerous. Like I said, about 85% of the cells within the CNS are actually neuroglia. So they play a few different roles. They play a role in supporting the the structures of the nervous system. They play a role in nourishment, and they play a role in protection to neurons. Okay, and so in order to do that, they're divided up into several different kinds. Okay, so what we have is we have our microglia, and the microglia are actually kind of rare within the CNS, but what they do is whenever there's any damage to the neurons, they actually become active and go to the site of that damage and phagocytize the tissue or the debris. Okay, so what these do, let's see, where's our cursor? There we are. So we'll say they help with damage. And what they do is they go and they phagocytize. How do you spell phagocytize? C-Y-T-I-Z-E. So they go to the site of the damage, they phagocytize the debris, and that plays a role, obviously, in protection and everything of the cells. And then we have our oligodendroglia. And what those really do, and this one might sound familiar, oligodendrocytes. These oligodendria, what they do is they play a role in the myelin sheath. Okay? So they play a role in actually the formation of myelin and the creation of that myelin sheath. And then we have our astrocytes. Okay? And our astrocytes, they provide nutrients and regulate the chemical environment. They form the blood-brain barrier. So that's the one we're going to really focus on. We're not going to talk a ton about the blood-brain barrier in this lecture, but we'll get into it a little bit later on today. And then they provide structure and support to nerve cells, and they play a role in synaptic transmission. But the thing we're gonna remember here is the blood-brain barrier for our astrocytes. Okay, and then we have our ependyma, and they line the ventricles of the brain and the central and the spinal cord, and they aid in secretion of CSF. Okay, so those are 4 types: microglia, oligodendroglia, astrocytes, and ependyma. Okay, so microglia, damage, phagocytize, oligodendroglia, myelin sheath, astrocytes, blood-brain barrier, ependyma, CSF. So those are really the 4 types of neuroglia. And then we also have, so here's just so here's a little picture of the different types. So here's our microglia. That's going to play that role in phagocytosis. And then we have our oligodendrocytes, which play a role in the formation of the myelin sheath. As you can see here, they kind of play this role in the support and of the myelin sheath. Astrocytes, so the astrocytes of the blood-brain barrier, and then we of course have the ependyma as well, which isn't shown in this picture specifically, but this is basically a picture of these different cells and what they do. So we have our neuron, which we'll talk about in just a second, and that's surrounded by these oligodendrocytes, which create the myelin sheath, and then the astrocytes, play a role in the formation of that blood-brain barrier, and then we have our microglia. Okay. So after that, we then have our neurons. So what our neurons do is they play a role in transmission of impulses, and we have about 10 billion in our CNS. Okay, that's just a tremendous amount. That's pretty insane, but we have about 10 billion in our CNS, and they play a role in transmission of impulses. Okay, so we have our neuron, and coming off of that, we have an axon. Okay, and then coming off the axon, we have dendrites. Okay, and all these little branches here are dendrites. And then what would happen here is there would be another one, there'd be another set of dendrites here leading up to an axon and a neuron. Okay, and so that space in between, as you can see here, is a synapse. Okay, so that's the basic anatomy of a neuron, and then the neuron, the axon, is lined with this myelin sheath. And what the myelin sheath does is it plays a role in allowing the transmission to travel faster. So it actually allows it to kind of jump the synaptic cleft here, or not the synaptic cleft, sorry, the little node of Ranvier. This is node of Ranvier. So it allows the transmission, the little impulse, to actually hop over and travel much faster. Okay, and then, like I had said, the little synapse is going to be here in this little synaptic cleft here. Okay, so that's the myelin sheath, the neuron, and that's kind of how that works. Okay, so we have a couple different pathways that these impulses can actually travel. So the direct, and this is by the direction of the impulse. Okay, so we have afferent and efferent. Okay, and what happens here is, so we have afferent impulses, and those travel, they're sensory impulses, and they travel to the spinal cord or brain. Okay, and then we have efferent, and those are motor, and they travel away. Okay, so afferent pathways mean that it's a sensory impulse traveling to the spinal cord or brain. Efferent means it's a motor impulse and it's traveling away from the spinal cord or brain. Okay, so one little mnemonic some people use is SAME, meaning sensory afferent, motor efferent. Okay, afferent, efferent. Okay, and so those are kind of different, the two different ways that an impulse can travel, either to the brain or away from the brain. In order to allow for those impulses to travel, we have what are called neurotransmitters. And what they do is they play a role in facilitating the transmission of these impulses. And so this is just a little picture here. This obviously isn't a real picture. This is kind of just an illustration. But what we have here is we have this little synaptic cleft here between these two little axons here. And what will happen is you'll have these little neurotransmitters that become kind of vesselized here, and what they'll do is they'll travel toward the synaptic cleft, and as they do so, they'll open and they'll eject these little neurotransmitters into this space here, and they'll go and they'll bind here on the receiving end. And what that does is it facilitates the transmission of these impulses. Okay, so we have a couple different types. We have excitatory neurotransmitters and we have inhibitory neurotransmitters. So that's really kind of the role that neurotransmitters play. And of course, you've probably heard of different neurotransmitters like acetylcholine, norepinephrine, dopamine, serotonin, GABA are some of the ones that you're definitely gonna know about. But let's look at it just a bit more. So these are neurotransmitter systems in the brain. These are some of the important ones. So noradrenaline travels via noradrenergic pathways. Dopaminergic is going to go, or dopamine is going to go via dopaminergic pathways. Histamine, histaminergic, serotonin, serotonergic, and acetylcholine via cholinergic. So what happens is, in order to facilitate transmission of these impulses, these neurotransmitters become involved. Okay, and once they have done their job, you actually have enzymes come and kind of take these out of this space here and bring them back in. Okay, so they can be then reused and stuff. So for example, like cholinesterase deactivates acetylcholine. So you'd have acetylcholine would come and try to facilitate transmission, and then cholinesterase would come and take acetylcholine back in, and that would be the way that would go back into the system. Okay, so that's kind of how those neurotransmitters work. We can get much deeper into neurotransmitters, and there's a lot of different. There's many different neurotransmitters, and there's many ways that they work, and there's many pathways by which they work. But those ones that we talked about just briefly here are going to be the ones that you would need to know. And of course, like with your sympathetic nervous system, with your fight or flight, we're going to be dealing with acetylcholine quite a bit. So they just kind of play a different role in how impulses are initiated and travel within the system. Okay, so let's just talk really briefly about cerebral metabolism. So the brain requires a tremendous amount of oxygen in order to work. It actually uses about 20% of cardiac output and 20% of the oxygen delivered. So it uses a tremendous amount of the oxygen that's delivered to it, and it requires about 20% of total cardiac output. So that's a very high amount. And and the brain is very sensitive to changes in oxygen delivery. So the second that we decrease that cardiac output and the amount of oxygen that's being delivered to the brain, we start to see changes. We start to see altered mental status as the oxygen delivery decreases to the brain. So that's why we are very cautious when we're monitoring our patients' pulse ox. It's not an incredibly reliable source for monitoring oxygenation and everything, but it gives us an idea of tissue oxygenation. And of course, when we talk about tissue oxygenation, we're talking about every tissue, but especially we're concerned about oxygenation of the brain, as it requires so much in order to be able to function. And we can actually lead to these anoxic brain injuries. And and that's why we talk about if CPR isn't started within 10 minutes or so, you've kind of missed your boat of being able to revive the person and reoxygenate their brain and everything like that. So it's very important that we keep people oxygenated. It's very important that they're getting enough oxygen up there. And then, we can get into it later. We've talked in the podcast a few times about stroke and what cerebral perfusion pressure is and all that, and how to calculate cerebral perfusion pressure. But the reason we're calculating that is, of course, because that tells us basically how much blood is able to get to the brain. And if we're getting adequate amount of blood to overcome, like our ICP and things like that. And if we're not able to do that, then we run the risk of the patient not receiving the oxygen they need. And then the brain, of course, also has a tremendous energy need. So there's a massive energy need in the brain. Now, the brain actually does not need insulin to use glucose, but it does require a significant amount of glucose in order to be able to function. Now, hypoglycemia, of course, is associated with neurological change. The brain needs glucose, and it uses glucose so triggered by the sympathetic nervous system, gluconeogenesis, it plays a role in the conversion of fat and protein to glucose. And then, again, as that happens, the brain does not require that insulin in order to draw glucose into the cells and allow it to use it. But neuro changes will occur when blood glucose reaches about 50 to 70. You might start seeing neurological changes within your patients. That's why, of course, if you have a patient whose blood sugar is under 60, a lot of times you'll have a standing order to deliver a half amp or an amp of D50. And that's to get that blood sugar up. And there's other reasons, of course, too, but getting our blood sugar below this state can lead to neurological changes, and we don't have the energy that we need in order for our brain to function. And then if the blood sugar gets below 20, you'll actually have the patient, it can possibly result in a coma. Now, this is one of the most common reasons that I see like urgent assessments and things called within our hospital, is that the patient's blood sugar dips down below 20. And I've seen it, as low as 12, as low as 10, and it is reversible. But that's kind of the reason that, we check our blood sugars often, a lot of times in the hospital, and we deliver either insulin or D50 as needed in order to keep blood sugars in an appropriate range. And that's why, too, if a patient comes into the hospital experiencing stroke-like symptoms, one of the first things we're going to do is we're going to check blood sugars. And the reason we're doing that is to determine, is this altered mental status a result of decreased blood sugars, or is this person really experiencing a stroke, possibly? So that's kind of one of the reasons that we're going to check blood sugars immediately prior to giving someone TPA or anything like that, is so that we can determine the reason for the neurological change. But yeah, like I said, it can be reversible. We put them on insulin, or we put them on intensive blood sugar management, and we'll be checking their blood sugar every hour at the most, or at the least, and then delivering what's needed in order to get that blood sugar up and within an appropriate range. And then hyperglycemia, what can happen here is we have this osmotic effect, which can lead to brain dehydration. We have another video on here that talks about the osmotic pressure and things like that. But what can happen is if we have a tremendous amount of glucose molecules within our bloodstream, what's going to happen is, of course, this blood then becomes hyperosmolar, meaning that there's more solute within the blood than there is in the intravascular space. So what's going to happen is it's going to draw fluid into the blood vessel in order to balance out the concentration of blood sugars within here, or of osmolarity within the vessels and without the vessels. So what's going to happen, and if this happens within the brain, what it's going to do is it's going to draw fluid out of the brain cells, out of the brain tissue, and into the vascular space within there, and that can lead to brain dehydration, which of course is a bad thing. So we're going to want to make sure, so there's reasons to watch out for hypoglycemia and hyperglycemia that relate specifically to cerebral metabolism and neurological status. Okay, hope that makes sense. If that doesn't, check out our video on the osmotic pressure and hydrostatic pressure and everything. All right, so that is that. And then lastly, we're just going to talk about the blood-brain barrier. Now, what a lot of people might think is that the blood-brain barrier is like this physical structure that sits underneath the brain, where the brainstem comes in, and that it's some sort of structure that actually limits what can get into the cerebral cavity. Now, that's not true. It's not an actual structure. What the blood-brain barrier actually is it's really just a set of characteristics of the cerebral arteries, and the choroid plexus that prevent different toxins, medications, and different things from actually entering into the brain blood flow. So that's really kind of what it is, and it acts to limit the transfer of those substances into the cerebral spinal fluid and into the extracellular fluid within the brain. And so by doing that, we can protect that brain tissue and ensure that we're protecting, like, the home base. We're making sure that the brain is safe and that there are no concerns with the brain there. Now, it's important, so like for Parkinson's, Parkinson's has to do with dopamine and those dopamine receptors within the brain. And so what we have to do to get drugs to there is we give levodopa, carbidopa. Oh, geez, I don't even know my carbidopa. And the way that this drug works is it works hand in hand to potentiate or to allow the drug to actually enter into the blood-brain barrier. And without giving these two together, the drug actually isn't able to enter the cerebral cavity and the patient isn't able to receive the medication they need. Okay, so that's really kind of what the blood-brain barrier is. So that is our video today, just basically covering the micro anatomy and the micro structures of the brain. And in the next video, the microscopic structures of the brain. Next video, we'll get into more of the macroscopic structures, the bones, the brain tissue, and the anatomy of the actual brain. And then we'll get into some of the disorders. So that's basically it for today. If you want to check us out, visit us at nrsng.com or nursingstudentbooks.com. Make sure you check out our apps, our NCLEX prep apps. We have RN Crush and SimCLEX, the two best apps to help you prepare for the NCLEX. You get bored of studying, RN Crush is a great way to relieve some of the stress and just play a game while you're still studying. And SimCLEX is the one and only legit app that actually simulates the NCLEX. It's actually computer adaptive and responds to the way that you're taking the test. Also, if you want to visit us or if you want to contact me, you can email me, contact@nrsng.com. I'd love to hear from you. Check out the blog, and we will talk to you later, guys. Thanks so much.